Hello, can you hear me?
Yes, sir.
আদাব স্যার, আমি ডক্টর শারমিন বলছি, আপনার স্টুডেন্ট।
ও শারমিন, কেমন আছো তুমি?
জি আছি স্যার, অনেক অনেক দিন পর দেখা হলো স্যার। আপনি ভালো আছেন?
আছি শারমিন, ভালো আছি। হ্যাঁ, তোমরা কেমন আছো?
জি আছি স্যার। আপনি এত ব্যস্ততার মধ্যে যে আপনি আমাদেরকে সময় দিয়েছেন, আপনি একটু ট্রাভেলিং এ আছেন আমি জানি, তো আপনাকে এর জন্য অনেক অনেক ধন্যবাদ।
না ঠিক আছে, আমার হঠাৎ করে একটা এনিওয়ে, এখন কথা হলো যে এটা আমি একটু কনসার্ন ছিলাম যে কতটুকু আইটি প্রবলেম হইতে পারে এইটাই।
না, আমাদের লাবিবা 80% যে আছে সে যথেষ্ট ভালো, অনেক এফিশিয়েন্ট, ইনশাআল্লাহ অসুবিধা হবে না স্যার।
হ্যাঁ, তো তুমি কি বাংলাদেশে নাকি ইউএসএ তে?
স্যার এখন বাংলাদেশে স্যার।
আচ্ছা আচ্ছা আচ্ছা, তুমি তোমার সবাই ভালো আছো?
জি জি স্যার।
থ্যাংক ইউ শারমিন। তো আমাদের এটা কি কেউ আপলোড করবে নাকি?
হ্যাঁ, লাবিবা করবে। লাবিবা,
জি ম্যাম।
হ্যাঁ স্যার কি চাচ্ছেন এটা তুমি কি করো। হ্যাঁ
স্যার আপনি কি স্ক্রিন শেয়ারের কথা বলছেন?
হ্যাঁ 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 হ্যাঁ,
আচ্ছা,
please.
আমি স্ক্রিন শেয়ার করব।
হ্যাঁ,
আচ্ছা স্যার, ওকে।
আর স্লাইড গুলো চেঞ্জ কি তোমরা করবে নাকি আমি তো করতে পারবো না, তোমাদেরই করতে হবে?
হ্যাঁ হ্যাঁ স্যার, আমি করে দিব, কোনো সমস্যা নেই।
ওকে, থ্যাংক ইউ লাইবা, থ্যাঙ্কস।
ওকে স্যার।
আমরা কি শুরু করবো নাকি আর একটু ওয়েট করবো? খুব
স্যার স্লাইড যদি বেশি থাকে তাহলে আপনি শুরু করে ফেলতে পারেন। 8 জন
আচ্ছা,
আছে এখন।
আজকে অ্যাটেন্ডেন্স কয়জন?
সাধারণত 16-17 জন হয়। এখন 8 জন আসছে, তো 10-15 মিনিটের মধ্যে শুরু হয়ে আরো বেশি হয়ে যাবে। কিন্তু আপনার যদি স্লাইড বেশি থাকে তাহলে শুরু করে ফেলতে পারেন।
আমার শুরু করাই ভালো নাকি 4-5 মিনিট? না ঠিক আছে, দেখতে পাচ্ছি আমি।
স্যার স্লাইড চেঞ্জ করার যখন টাইম হবে স্যার আপনি জাস্ট নেক্সট বললে আমি চেঞ্জ করে দিব।
ওকে ওকে, থ্যাংক ইউ। আমরা কি 2-3 মিনিট ওয়েট করবো নাকি শুরু করবো?
স্যার শুরু করে দিন স্যার।
Okay, thank you. Okay, let's start then. So good morning from me. I'm Dr. Amal Paul. I'm from Bangladesh. Not recently, for a long time, I'm living in UK. It's my pleasure to meet you all, and I hope you will enjoy the presentation on pre-pregnancy counseling and contraception. Next one, please. Now I will go at the first. I'll just let you know what we are planning from this presentation. I hope at the end of presentation you will understand what is contraception and family planning, what the methods we use in contraceptives, and risks and some benefits of the contraceptive methods. At the same time, hope you will also understand and the values of pre-pregnancy counseling. I might, if I have some time, I might touch on a little bit on antenatal care, but it depends, see how we are doing with this presentation. Now, during the presentation, you may feel free to ask questions, but it will be better if we leave at the end, then we can discuss any question you have, or if you have any suggestion. Next slide, please. Often we use interchangeably the words contraception and family planning. Well, this family planning, it can encompass whole spectrum. But if you go on definition wise, contraception means it is intentional prevention of pregnancy. And family planning, this is the desire of the couple, how many of the children they will have. So in Bangladesh, we usually use the word family planning to encompass the conceptions of contraception and making a limited number of the children or desired number of the children. Second, next please. Often we think that contraception is only to prevent pregnancy or just to have a number of children in the family, but in fact, it is. And it gives the women some power. At the same time, we see the use of contraception throughout the world is a quite popular method by the family and by the couples. If you consider the whole world as a family, 1.9 billion of the members, especially the women, they use contraception throughout their reproductive life. But however, even then, there is a number of people who are not using them, whom we call, they have unmet need, and that is 270 million of the women. Contraception just not only, please go back to the slide before. Yeah, contraception doesn't only prevent pregnancy-related problem, it also increases the good health of the mother to space in between the two pregnancy, and some form of contraception, they give extra protection to the mother, like condoms, which prevent sexually transmitted infection. It has got some non-health benefits, like they give the mother the opportunity to get on with the education. They give the women empowerment to protect and plan their own health, and also help the sustainable population growth. Not to mention that every woman or every man, they have the rights, the human right to have the desired number of the family, and that can be offered through the use of contraception. So contraception is not only the prevention of pregnancy, it has got other health and non-health related benefit. Next slide, please. In Bangladesh, nearly 62% of the couple that use contraception, and worldwide it's slightly better than Bangladesh, like 64%, but we are well ahead of India with 58%, Nepal 50%, Pakistan 35%, and Afghanistan 23%. Next slide, please. Next slide, please. Now the conception starts with discussion with the mothers, with the women. And in this concept, you can see the photograph I just used from the rural Bangladesh. People, they meet in a communal setting to discuss the methods of contraception with one of the health workers. I think this is a very powerful image to see that women should be empowered to talk to the same gender, to discuss freely their needs and their requirement. Because when this method or message is delivered by men, usually in our society, the women get shy and they don't ask questions, and hence they don't get the information. And when there is a lack of information, there is a lack of empowerment. So this is a message you should have in your mind, that when you devise a contraception clinic or service, you should think of delivering this message through the same gender, but not necessarily always it is true, but it is better. Next slide, please. Now, going back to the point of contraception, there are several methods of contraception used nowadays, which are traditional, like safe periods, withdrawal hormonal progesterone pill, combined pill, non-hormonal like barrier contraceptions, IUCDs, copper or hormone implanted, reversible long-term, again the IUCDs and implants, non-reversible long-term, that is male and female sterilization. If you go back to the history of contraception methods started in Bangladesh, late in 70s and 80s, the non-reversible and non-hormonals were not that promoted. It was promoted the sterilization one. Sterilization contraception was a preferred method we are using that time. This is a busy slide, and I would ask you just to have a glance, and you will get the copy of this presentation, so you'll know that is how the different methods of contraception, what is the effectiveness. If you see that the least effective is male condom, which is a high failure rate of 13, and the most effective form is implant and IUCDs. But at the same time, it depends how the implants are inserted, how long they are there, how they're changed, and so on and so forth. Next slide, please. Yeah, this is another one. I just want to draw attention that the sterilization which we are talking about, we are promoting back in 70s, 80s in Bangladesh, that is the male sterilization called vasectomy and female sterilization called tubal ligation. And they have pretty good effectiveness. It varies 0.5 to 1.15 failure rate. So failure rate is pretty small, and it was dependent on the people who are providing the service. And another thing I just want to highlight, that a method is often used in our country called withdrawal method, which is has a very high rate of failure, that is nearly 20%. And this should not be used as a reliable form of contraception. It has got other risks as well, and that includes the risk of sexually transmitted disease. So as far as possible, it should be discouraged. But if the couple is not happy to use any methods and use only that happy to use this method, yes, you can advise them, provided they understand the risks and benefits. Next slide, please. Again, this is again a busy slide. You can see that I just use the photos to see different types of contraceptions and their effectiveness. Next slide, please. If you see the side effects of the contraceptive methods, you know this, if you take a medicine or use a methods which is outside the natural habitat, then you invariably you'll have some side effects. The most common side effect from using contraception, especially the hormonal contraceptions in women, is the weight gain. And sorry, can you make it bigger, please? Okay, yeah, that's fine, thank you. There's a weight gain. That's the most common side effects, and that followed by the loss of libido and leg swelling, mood swings. But important, and sometimes it could be life-threatening, that is venous thromboembolism and neoplasm, especially the breast cancer. So when you prescribe a hormonal contraception, whether it is progesterone only pill or combined pill, you please make sure you counsel the women or men, especially the women, that there is a potential risk of long-term complications, including deep venous thrombosis, that is blood clots in the calf muscles, and neoplasm, mainly the breast cancer. It doesn't happen within 6 months, but it is a risk if they're using for a long term, say 3 to 5 years or 10 years. And you must take the history of this woman when you prescribe, whether there is a family history of breast cancer. We'll go through this later on. And you can see again, this is a long list, and I would urge you to continue reading this slide when you get the PDF form, and keep it in your mind when you counsel a woman about common contraceptive methods. Next slide, please. Just to re-emphasize, that's what the risk of contraception, especially the hormone one, is deep vein thrombosis, breast cancer, and coronary heart disease. Not to mention that there's a failure which may result in pregnancy. We have to mention this because if there's a failure of contraception and the women get pregnant, they might come back to you and they can't legal action against you that you prescribe contraception, but it didn't work. Provided you counsel them when you prescribe, you have a defense. Another serious side effects is the pelvic floor injuries and also injury to the uterus. When you insert a IUCD, there's a potential risk that you perforate the uterus, and also there's a risk that the abdominal, intra-abdominal organs, include the bowels, they are perforated or injured. This is not very uncommon, and it should be taken very seriously. Next slide, please. Now, an often question asked when you prescribe a oral pill, if I miss a pill, what should I do? We call it missed pill regime or missed pill advice. So let us see what is the missed pill, what are the risks and management. Risk of missed pill is that there's an increased risk of failure and hence pregnancy. Next slide, please. And second question come, how would we manage it? Next slide, please. Right, okay, so missed pill means a woman forgot to take in the pill. Say she take the pill usually 7 o'clock morning. She was busy, she didn't take the pill, remembered maybe in the evening, maybe following day, maybe another 2 days time. So this is by definition, the women missed a pill, and what she would do or what you are going to advise them. First thing is, you must explain to women the risks, not to panic, and then you advise what to do. There's a few rules. If you remember, the pills missed in week 1 of the taking pill missed in week 2, and pill missed in week 3. So if it is pill missed in week 1, you say, take the pill straight away as soon as you remember. Use extra precautions, mainly the barrier contraceptions, maybe for next 7 days. And if they have, in the meantime, have unprotected intercourse, they should be advised for emergency contraception, which will come later on. If the pill is missed in the 2nd week, then again, take the pill straight away and use extra contraception for next 7 days. Now the question is whether there's a need of emergency contraception or not. Yes, emergency contraception you can use, it is discretion on you. And whether the women had unprotected intercourse during this time, and you think that there's a risk of pregnancy, yes, you can. Otherwise, just these 2 things. 1, take the pill straight away and use extra contraception for 7 days. And if the pill is missed in the week 3, then take the pill straight away, omit the pill-free days. You can remember, usually the 28 days pill, that is 3 weeks of, or that is 21 days of active pill, either estrogen or progesterone different in concentration. And the last 7 days, this is called pill-free, but the women take the pill, but that is iron tablet, not any active ingredient. So that you should ask the women, please take the pill straight away. Don't stop the pill. That is, you take the 7 days, the non-ingredient containing pill and start immediately the other pack. That means you are not having any pill-free day. So this is a very important thing, that you should not use any pill-free day, but you advise them for the need of barrier contraception, including the condoms. So can I go back and explain to you again, especially that if the pill is missed on the 3rd week, so we ask the women to take the pill, immediately when they remember. Second, to start the next packet immediately and use barrier contraception for 1 week. This is very important because the any pill missed in the 3rd week is associated with increased risk of failure and pregnancy. Next slide, please. Next slide, please. Next slide, please. Thank you. Now, emergency contraception. What is the emergency contraception and what are the benefits and risks we have to concentrate now? Next step, please. Emergency contraception means women, they feel that they need contraception because 1, they had unprotected sexual intercourse, or 2, they are using some form of barrier contraception, it didn't work, or 3, she had been a victim of rape or sexual violence or abuse. Whatever the reason, if a woman comes forward and asks for emergency contraception to avoid pregnancy, you are morally and ethically and legally bound to prescribe emergency contraception. There are different types of contraception for use in emergency. And if you think one method is not suitable for her, then the other form of method you can use or advise. But please be sure that you are providing some form of help. So if a woman coming to you within 24 to 48 hours, you can use a tablet called levonorgestrel. It is basically a progesterone pill, and it's best effective if you can prescribe within first 24 hours of having the unprotected intercourse. There is another one tablet called ulipristal. This is also a form of progesterone only pill, but it is very effective until 120 hours. That is 5 days. Now the question is whether you should use levonorgestrel from the beginning or ulipristal from the beginning. Research has shown that if you use ulipristal for the first 12 to 24 hours, it is equally effective as levonorgestrel, but after 24 hours, the levonorgestrel effectiveness reduced, but ulipristal, it retains its effectiveness. From the point of view of prescribing, you can prescribe both of them, but I think if you use first 24 hours levonorgestrel and then from 24 hours to 120 hours, you can use ulipristal. That could be a better way of prescribing. The other two methods, other one method is used, many people they do, that's a copper IUCD, not hormonal one. The copper containing IUCD, you can use from the beginning until 7 days of having the unprotected intercourse. But the problem with this emergency contraception prescribing, that you must make sure that women is not at risk of having sexually transmitted disease, especially if that sexual encounter happened during a sexual violence, rape, or having a one-off intercourse with an unknown person. And the third one, I'll talk about the postpartum contraception. So what is postpartum contraception? It basically means that you provide contraception advice and method after the childbirth. And why we do that? Because in many cases, the women, the one, and some cases, you think as a medical person that she should be protected from future pregnancy, like she had 3-4 cesarean section, she had difficult birth, she had injury to the birth canals, like that. And now we can discuss about the benefits and the risks. Next slide, please. One is common form of postpartum contraception is we call LAM, which is lactational amenorrhea method. That is when the baby is born, mother continues breastfeeding, that gives the lactational amenorrhea, that is an ovulation, and that protects them from pregnancy. But this method is not very reliable, and it should not be continued more than after 6 weeks. So people who are interested for contraception should be prescribed either progesterone only pill, progesterone injections, or IUCDs. You can also use implants. Combined oral contraceptive pill you should use very carefully if it's breastfeeding. And condom is not very effective. Natural family planning methods are not very effective either. Some people, they use after 6 weeks IUCDs and implant, and in my opinion, that is the best thing for a woman to have contraception. Again, if the woman is having cesarean sections, maybe 3 or 4 cesarean sections, and they consented for contraception during cesarean operation, they can have tubal ligation. But again, there must be a good counseling, because in our country, the perinatal death is quite high, and if the child passes away very unfortunately or tragically, the mother can suffer from emotional upset. So that point must be taken into consideration and discussed with the mother before a tubal ligation is performed during cesarean section. Next slide, please. So if we take one or couple of points from this presentation, that what we learned today, as I said, I'll say this is the take-home message. The contraception is to be individualized. That is, not a single method is applicable to everybody. So individual men or women should have individual choice. You must take appropriate and relevant history before you prescribe contraception. In primary care, I cannot emphasize more that you should not prescribe any contraception method without taking a proper history. Especially when you prescribe combined oral pill or hormonal contraception, you must make sure that you take the history and take a note that about their previous mental health problem and family history of cancer, personal history of cancer, and also that any evidence of deep vein thrombosis, including pulmonary embolism. It does not mean that if they have a history, you cannot prescribe contraception. It only means that you can individualize and prescribe a more effective and safe contraception method to that woman or man. You must consider the risks and contraindications, and you must discuss it with the women. Emergency contraception should never be withheld. You might have hesitancy. You might not agree with the women's request for emergency contraception, but you cannot withhold. This is not moral, ethical, or legal practice, because the women, they have their own right and choice to have a pregnancy or not to have a pregnancy. So we must respect this one. And long-term reversible contraception should be encouraged. Now, how can we do that? It is again through discussion and counseling. If you discuss with women the risks and benefits of different types of contraception, and then you provide them an option, they can make a decision. But if you emphasize more that the risks and benefits of long-term contraception, especially the women, they might consider it more positively than if it is not discussed in good details. Next slide, please. Right, before going for a comfort break, it is already we have talked about 30 minutes. Is there any questions or any point you want to discuss? Can you go back, Nabila, and see whether they have any question to ask? Hello? Before going to next one, can we take some break, please? 10 minutes break?
Okay, sir.
Anybody have got any question? Before going to break, do you have anybody have any question?
স্যার আমার মনে হয় আমাদের কোনো কোশ্চেন নেই, আপনি নেক্সট টপিক চলে যেতে পারেন স্যার।
আমি শুনতে পাচ্ছি না, একটু প্লিজ স্পিক আপ।
স্যার আমার মনে হয় ওনাদের কোনো কোশ্চেন নেই, আপনি নেক্সট টপিক চলে যেতে পারেন স্যার।
Let us take 5-10 minutes break.
Okay, sir.
Can we reconvene 10 minutes time?
স্যার 5 মিনিটস হলেই ভালো হয়, 10 মিনিটস বেশি
Okay,
হয়েছে।
5 minutes, thank you.
ওকে
Okay, that's all right, thanks.
স্যার আপনি শুরু করে দিন স্যার।
Okay, thank you. Welcome back. Now, the second part of the talk, this pre-pregnancy counseling and care. Oh, Sharmin, should we touch on the antenatal care or we leave it?
ইচ্ছা আপনি যেভাবে কমফোর্ট ফিল করেন স্যার।
Okay, let's see. আমাদের pre-pregnancy counseling এবার দেখি anyway. So, can I next slide, please? Okay. So pre-pregnancy counseling and care, we will just discuss the aims and objectives. That is what we are going to achieve through the pre-pregnancy counseling and how we can achieve the goals. When we talk about pre-pregnancy counseling, often not only the patient, but the doctors as well, they get lost, confused, not sure what to tell and why they tell and how the message will be delivered. And let us go through this process and see whether we can make some sense out of this. Next slide, please. Next slide, please. Labiba, next slide, please. Thank you. Now, what is pre-pregnancy counseling? Now, can I go back to the headlines? We have got three things in the headline. One, pre-pregnancy, that is before pregnancy, counseling, what we should say and what take care of them. Can I have the next slide, please? This we have gone by, yeah, thank you. This one, yeah. So pre-pregnancy counseling is a set of interventions which is to identify or modify the biomedical, behavior, and social risk to the women's health or pregnancy outcome through some intervention or prevention and management of the risks. So first, you need to identify whether there is a risk or not, and if there is a risk, what are the risks and how we can modify or eliminate the risk to improve the pregnancy outcome or reduce the risk of the maternal health. Next slide, please. If we think about 25 years or 30 years ago, the conception of pre-pregnancy counseling was not that much prevalent in obstetric practice. But with research and our experience, we have seen that a couple of diseases, they increase the risk to the mother's health and well-being, and not to mention the health and well-being of the newborn baby. And it first came to the knowledge of the obstetricians, the risk of neural tube defects through personal problem, effects of diabetes on maternal health and the outcome of pregnancy and the health of the newborn, the effects of other endocrine disease, including the thyroid disease, and some of the health issues of the mother, like having obesity, BMI 30 or above, alcohol abuse, drugs, taking some prescribed medicine, including anti-epileptic medicine, and women when they get pregnant at the age of 35 or more than that. So a couple of them is non-modifiable, like personal and family history of neural tube defect or age, or the BMI, which is a self-inflicted problem. But others are modifiable, like controlling diabetes changing antipileptic pill to a different safe one, reducing weight, and managing other endocrine disease. So if you talk about pre-pregnancy counseling, you can see we have some modifiable disease and some non-modifiable problems. So first thing, we need to see who would benefit from pre-pregnancy counseling. Next slide, please. There's a list of other people who can have benefit, like people who have inflammatory bowel disease, renal disease, cardiovascular disease, mental health problem, hematological disorder, autoimmune disease, and chronic respiratory diseases. And there are lots of other diseases which can be modified before the woman gets pregnant. So if we identify this group of women and offer them advice to manage their health problem and to remove some risk factors from their lifestyle, the outcome of pregnancy could be better. We can have a healthy mother and a healthy baby with safe delivery. Next slide, please. Now, I will concentrate now for a few issues which, as an obstetrician, we can really make difference, like gestational diabetes, women with a history of gestational diabetes, preeclampsia or eclampsia, pregnancy-induced hypertension, small for gestational age. These are the high-risk factors. These are the high-risk mothers. Those people who are practicing obstetrics, they all know that a woman who has gestational diabetes in the past is at increased risk of having same problem this pregnancy. Preeclampsia, eclampsia, we know this, how that can affect the maternal health and outcome of the pregnancy, and how that can be very catastrophic effect on the outcome of the mothers. And small for gestational baby, there again the risk both to the mother and the child, and not to mention the anxiety among the family. So this group of people, you should take into consideration for serious pre-pregnancy counseling. Next slide, please. Now, how we can organize pre-pregnancy counseling and care? In my opinion, the first thing that we need to inform the people, the public, about the pre-pregnancy counseling, its aims, objectives, and who can get benefit and from where this service can be obtained. Because if you don't give this information to the general people, the service will not be utilized and the benefit cannot be delivered. So from where this pre-pregnancy counseling can be offered? One, from the pre-pregnancy clinic. You might have been dedicated pre-pregnancy clinic. You can discuss the during the discharge from the hospital. You can discuss the issues they have during the pregnancy or childbirth, including preeclampsia, diabetes, and what could be the effect during the next pregnancy or in future pregnancy. And during that counseling, a health diet sheet can be given to them with advice in healthy eating, taking vitamins, supplements, making best use of their daily lifestyle, including reducing weight gain, maintaining a good life habit, taking exercise, stay active, to stay away from using risky substances, including drugs, alcohol, smoking. And most importantly, they understand the use of prenatal testing for chromosomal abnormalities. Those of you who has some training in obstetrics, they understand that there is a protocol to, we call it screening for chromosomal abnormalities among the newborn babies through doing some tests at 12 weeks gestation or 12 to 14 weeks, and also doing a scan in between 20 to 24 weeks. Down syndrome is one of them. And I'm sure we can discuss in future how these systems, how this disease can be, or conditions can be diagnosed, and how it could be avoided in future pregnancies. Next slide, please. No slide before, please. Just we missed a slide. Nice, thank you. No, we have gone a bit far. Can you go back,
This
please?
slide.
Go back, please. Previous.
লাবিবা তুমি ব্যাকে যাও, ব্যাকে আরেকটা স্লাইড ব্যাকে যাও।
Back,
হ্যাঁ এই যেটা।
back, please, back.
আরেকটা স্লাইড ব্যাকে যাও তুমি।
Yes, that's fine. So that was the last slide I was talking about. And go to the next one, please. Thank you. So in pre-pregnancy clinic, pre-pregnancy counseling clinic, this following information should be given to the women, but it is not exhaustive. You can add to that. It may not be applicable to all women, but you can take it as your protocol to talk about that. On the diagnosis of pregnancy, or before the pregnancy, they come to you for advice, we usually ask them to take folic acid, vitamin D, oral iron. Now, there is a controversy about the dose of folic acid. I have encountered so many times. What is the dose? Some people, they say they give 400 microgram, which is usually available in multivitamin capsules. And the other tablet, folic acid tablet, are 5 milligrams. So it's a huge difference in 400 microgram and 5 milligram strength. The folic acid, if you want to give it to avoid or prevent neural tube defect, it should be 5 milligram. 400 microgram is not good. So you should consider the dose. Second is vitamin D. Again, vitamin D, how much you want to give, that depends whether you are treating vitamin D deficiency or you are giving vitamin D to maintain a good vitamin D level during pregnancy. If it is for prevention, that 400 international unit is fine. But if it is lack of vitamin D, you should consider 20,000 units monthly. And it depends on you as a clinician and the patient as whether they have the deficiency or not. Oral iron, I must mention one thing here. Oral iron, we use usually ferrous sulfate. When I was working in Bangladesh, we were using Folfitab, which contained oral iron and folic acid. And it was a very cheap but very effective medicine. Now I understand that Folfitab may or may not be available, but oral iron and folic acid are available there separately. The dose of oral iron is 200 milligram ferrous sulfate, 200 milligram daily. The reason I'm mentioning it, the dose, that it was prescribed before, ferrous sulfate, 200 milligram 3 times a day. That's not a right dose. It is just wastage of the medicine. It is not absorbed and it gives more side effects including constipation. So please don't prescribe ferrous sulfate 200 milligram 3 times a day. Ferrous sulfate 200 milligram 1 time a day is enough. Then stop smoking, advice to stop smoking. It's not very common in our country, the women to smoke, but it is not unusual in the society now. So you should ask them to stop smoking. You can tell them, you can advise them what are the risks coming with the smoking, including the risk of small for growth babies. Alcohol, they should cut out alcohol and should stop. You know, the alcohol baby syndrome is a common problem in case of alcoholic mother. Healthy weight, maternal weight has got significant depend on the outcome of pregnancy and the baby's weight. So they should not have obesity, neither they should be underweight. So a healthy weight to be maintained, and that can be advised through eating properly and not to continue dieting. This is one of the issues we face as obstetrician and also in the primary care, that the women, they want to keep them underweight through eating less, but they should understand in pregnancy the requirement of the dietary requirement, including carbohydrate, protein, and fat, is much more than if they're not pregnant. Up-to-date vaccination and immunization is very important. They should continue to have the flu vaccine and other vaccines, including the COVID-19 vaccinations. You have seen that during the pandemic, a number of women, they suffered severe health problem, including death, when they didn't have the vaccination. So you please advise them to have the vaccines as they are advised by their government. Different country has got different requirement and they should follow that. Another thing is the control of long-term condition. Now, what are the long-term conditions the mother can have? All women, they should be screened for their healthy life habit during the pre-pregnancy counseling, and it includes diabetes, thyroid problem, and other probably including the kidney disease. So diabetic control is very important, because if the diabetic control is not good, then there is a risk of complications of the babies and the pregnancy. So that's so important. Second important thing is the control of thyroid disease. You all know that uncontrolled thyroid problems, the pregnancy loss is more than if it was controlled. Other problems like sickle cell anemia, thalassemia, you understand that this is again the non-modifiable disease, and that you need to keep the women under close monitoring, and to make sure that their hemoglobin are not too low. And when the women, they are coming for pre-pregnancy counseling, they should also be advised that they should have pregnancy at their best time of their life. It doesn't mean that time, I mean time in terms of day or months. I mean in terms of their health controls, like when the diabetes is well controlled, their weight is not unusually high, or they're not very underweight, or they don't have uncontrolled hypertension or any other problems. And also we need to organize the supports and assistance. The women may need supports, emotional and psychological. They may need assistance from the family, from the other doctors. So you need to advise them accordingly. So these are the really package of the advice you should give during the pre-pregnancy counseling period. Next slide, please. So this is the thing you can do in the community. When they come for any reason, check the blood pressure, see if you got to have the weigh machine, weigh them, and see whether they're underweight or not. And then you start things. I'm just going through quickly with antenatal care if time permits, Sarmin. Okay, I'll just finish within 5 minutes. Can I have the next slide, please? Now, pregnancy is a very exciting part of mother's life. The mothers, they feel fulfilled. The women, they feel the life is fulfilled when they are women. When they have transformation from women to a mom, to a mother. So we can help them through the risky journey of the pregnancy and childbirth. And then we can, that should be started when they come forward first time to have a pregnancy test or report that they are pregnant. Next slide, please. So what we should do, we should prepare the women for a safe and enjoyable pregnancy. We monitor the mother and we aim for a safe and planned delivery. And it is not available maybe in Bangladesh, then we call it parenting preparation, when the both mom, to-be mom and to-be dad are invited to attend meetings where the whole process of pregnancy care, what will happen after the pregnancy, delivery, and what challenges they will feel when they have the small baby. They discuss this. That is, the mothers and the fathers that prepared to go together through the journey of pregnancy, childbirth, and the early postpartum period. Now, during this period, again, what we mentioned during the pre-pregnancy clinic, pre-pregnancy counseling clinic, you make sure that woman is taking the medications like folic acid, oral iron, and vitamin D. The weight is managed. They are not taking any untoward medications. They stopped smoking and alcohol has been withdrawn or they're advised to reduce it. And they have got enough family support, both psychological and emotional. Also, we will organize future care to detect early in the pregnancy complications like preeclampsia, eclampsia, gestational diabetes, and so on and so forth. Next slide, please. We define the pregnancy in 3 parts. We call it first trimester for first to 12 weeks, second trimester 13 to 27 weeks, and third trimester 28 to 40 weeks. Now, the antenatal care is more important for the second and third trimester, but fourth trimester is not often, it should not be ignored. This is the time when the women, they have all the morning sickness, nausea, vomiting, they don't want to eat, they don't want to go to work, and they have problem with their health. And if they have pre-existing health problem, that can get worse. The second trimester is the best time to prepare the women through the screening process to have a lovely and enjoyable pregnancy and a safe childbirth. And third trimester to follow up the baby's growth and also the maternal well-being, to prepare them for the birth of the baby and also to plan for the pregnancy outcome, like the delivery. Either it's a normal delivery or pre-planned cesarean sections, and that can be planned during this week. Next slide, please. What usually we do, as I told you, this the antenatal care really starts from the pre-pregnancy counseling. During the first trimester, they do the blood test and checkups like blood pressure, urine check, and blood test for hemoglobin, and other tests like whether they have got diabetes, pre-existing diabetes, and another any tests like thalassemia, hemoglobinopathies, not to mention that rubella, HIV. We should do all the tests during the first trimester of pregnancy. Then we organize regular antenatal clinic attendance. It varies from country to countries, but there should be a protocol and process, maybe 1 or 2 times during first trimesters, 2 to 3 times in the second trimester, or sometimes 4 to 6 times. And after 28 weeks, usually every 2 weeks. But again, all the visits should be managed and offered to the women according to their need. But what I told you, that should be the minimum. Next slide, please. So WHO, they gave at least 4 scheduled antenatal visits, at least 4. So first visit within first 16 weeks of pregnancy, second visit between 24 to 28 of pregnancy, third visit at 32 weeks, and fourth antenatal visit 36 of pregnancy. This is the bare minimum where no other services are available to look after the mother. But in the UK, usually 7 to 10 antenatal clinic visits are planned. I emphasize it is planned, but it can be increased according to the need of the mother. Now, if I go back on the antenatal clinic, few things I want to mention. That routinely the mother should have a ultrasound scan in between 12 to 14 weeks. We call it dating scan to see how many weeks the baby is there. Because if you do the early pregnancy scan, it is more reliable than for dating point of view than if it is done in advanced pregnancy. Another scan should be done in between 20 to 24 weeks of pregnancy to see whether there is any fetal abnormality. This is the time when the baby's growth is more or less detectable with the ultrasound scan, and it is possible to detect any gross abnormality there, including the Down syndrome and Edwards syndrome. In between 26 to 28 to 30 weeks, all women should have basic tests on diabetes, especially to detect the gestational diabetes. It is routinely done in the UK through the blood tests. If there are any doubt, then they have glucose tolerance test. But that is one of the things we can adopt in our country because we are fast growing country and we have lots of resources available there. An ultrasound scan can be done at 30 to 32 weeks to see whether the baby's growth is normal. And then from 34 to 36 weeks, they can go to their own obstetrician to plan for the outcome of the pregnancy, like normal delivery or cesarean section. So this is the gist antenatal care. As a GP, you will be involved when they come at the beginning. I reiterate again, this is most important thing for us as a GP to organize a blood test when we see the women, including the full blood count like hemoglobin, iron, and so on. And then we check the blood pressure, do the urine tests. Then we see them in between 24, 28 weeks to check blood pressure, urine test, and also test for gestational diabetes, organize a ultrasound scan if the one in between 30 to 32 weeks, and then refer to the obstetricians in between 30 to 34 weeks or 36 weeks to plan for their delivery. Next slide, please. So who can provide the antenatal care? The midwife, GP, and obstetricians. I'm not sure how much midwifery service is developed in Bangladesh, but is in the developed country, it's very well developed. and a significant part of the women during the antenatal period, they go to the midwives. The GPs are also involved. In Bangladesh, I think GPs will take over the role of the midwife, so they organize the antenatal care as a whole. And obstetricians, it is also a very common thing in Bangladesh. This is hospital-based service. Most of the women, they go to a obstetrician gynecologist, and they start their care from the first diagnosis until the delivery. But if the women goes through the midwife or GP, they should have the part of the antenatal care in the community, and delivery they should go to the obstetricians in the hospitals. Next slide, please. Again, where we can provide antenatal care is pregnant women's health, children's center, GP surgery, and hospital. If we consider in Bangladesh, we can say the pregnant women's home is possibility, GP surgery is a possibility, and hospital is definitely a place where the women go for the antenatal care. Now, if we want to develop a community-based antenatal care by the GPs, GPs should be more proactive to see the women either in their home, or they ask them to come to their clinic, and they organize, we call is office-based obstetrics care, where they can have blood pressure check, urine test, and the GPs can check their the progress of pregnancy, like how much is the fundal height, so on and so forth. And many GPs, they could be trained to do the ultrasound scan for the fetal growth. That can be done in the community, and it seems to be ambitious, but it's very practical and achievable. And that I rest in hospital, we know all of us that the hospital, they are welcoming the women from the diagnosis of the pregnancy until they have the delivery. Next slide, please. So all pregnant women in Bangladesh should have simple but well-planned antenatal care, which I think that should be our ambition. And we want to provide ensuring safe motherhood and a healthy baby, and reducing maternal mortality and morbidity, and not to mention the perinatal death. So that should be the aim of all antenatal care. But in Bangladesh, we have more responsibility and duties to our mothers and to the women of Bangladesh to provide a safe, effective antenatal care to ensure a safe motherhood, having a healthy baby, and reducing perinatal mortality, morbidity, and perinatal death. Next slide, please. And thank you. And this is our future. This is, we are looking for a happy family with smiley face, with healthy babies. Thank you.
আপনাদের যদি কোনো কোশ্চেন থাকে স্যারের কাছে আপনারা জিজ্ঞেস করতে পারেন, কারণ জিপিদের কিন্তু আজকের এই স্যারের যে টপিকসটা দেওয়া হয়েছে এটা খুবই একটা মানে কমন একটা বিষয়, যে এগুলো এই ধরনের পেশেন্ট আমরা প্রচুর পেয়েছি জিপিতে। এবং আপনারা যারা নতুন ডক্টর, তাদেরকে বলছি আপনাদের যদি কোনো কিছু জিজ্ঞেস করার থাকে অবশ্যই স্যারের কাছ থেকে আপনারা এগুলো জেনে নিন। আর স্যার আপনার নেক্সট ক্লাস হচ্ছে 30 তারিখে।
নমস্কার স্যার। Sir, I am Dr. Nozrul. I have a question on contraception.
Yeah, please.
Sir, a woman with diabetes, hypertension, having 2 children, her husband living abroad, comes every 2-year interval at home and stay for 2 months. Husband not agree to use condom. Woman wanting contraception method. Which contraception method will be suitable for her?
Now, this is a very interesting question. So basically, she had health problem, diabetes, hypertension, and also there is no need of continued contraception, isn't it? That is we are talking about.
Yes.
She needs the contraception when they want. Yeah. Am I right, Dr. Nazrul?
When husband comes home and
Yeah.
stay for 2 months. For 2 months, she want contraception.
Yes, that is the husband lives abroad, whatever, and she lives here, and whenever he comes here wants a contraception, but he is not happy to use barrier contraception like condom.
Yes.
Yeah, am I
Yes,
right?
sir. Yes, sir.
Yeah.
Yes, sir.
Yeah. So what are the options you are left with as a GP or as a doctor to advise them? You are left with providing some form of very temporary contraception, including the condom, but he's not happy for that.
Yes, sir.
That onus is now on the women to use the contraception, not on the man. The discussion should be around how you want to do that. Now, what are left with very conventional methods, that is withdrawal method, safe period method, but you don't know when the husband is coming, whether he's coming at the safe period or unsafe period. So that one thing. Withdrawal method we discussed is a high level of failure. So that is they can use, but that is again fraught with failure and pregnancy. So that mother can use vaginal condoms, which I don't know how much is available in Bangladesh. They can use clinical or chemical contraceptions like some spermicides
Yes, sir.
during intercourse. Withdrawal method, they can use withdrawal methods. And another one, you can ask or you can counsel the women to have a long-term contraceptions, non-hormonal, like copper IUCD,
Yes, sir.
which she can use, and she will feel safe whenever her husband comes home. She doesn't have to worry for pregnancy.
Yes, sir. Sir, I have another question.
Yeah.
After vasectomy, what are the risks of developing the testicular carcinoma? Are there any risks of developing testicular carcinoma or not?
But this
After
is an
vasectomy.
interesting question. So that if you go back to the vasectomy, you just tied the vas. So after the vasectomy, what happens? The sperm is not ejaculated, isn't it? So that should not have any impact on the testicular functions. And I have got no research to mention to you that it increases the risk of testicular cancer. But testicular cancer might develop after vasectomy, but it may not have any relation with the vasectomy. So far, I don't know, honestly. I don't have any research paper to suggest that.
Yes, sir. Thank you, sir.
Thanks. Any more question?
স্যার আপনার নেক্সট ক্লাস 30 তারিখে, এটা একটু মনে
30th
রাখতে হবে। আমি আবারও এসএমএস করব আপনাকে।
ঠিক আছে, আশা করতেছি কোনো অসুবিধা হবে না। আমি ওই সময় ইউকেতেই থাকবো।
স্যার টপিকটা মনে আছে, মনে করিয়ে দিব।
হ্যালো
হ্যালো স্যার, টপিকসটা কি মনে আছে আপনার স্যার?
আমার মনে হয় যে
ইরেকটাইল
erectile dysfunction
ডিসফাংশন
and
এন্ড প্রিম্যাচুর ইজাকুলেশন।
হ্যাঁ আমার মনে আছে।
স্টুডেন্টস, আপনাদের যদি কোনো কোশ্চেন না থাকে তাহলে আমরা আজকে ক্লাসটা এখানে শেষ করতে পারি। স্যার আপনার অনেক অনেক সুন্দর একটা প্রেজেন্টেশন হয়েছে, আশা করি স্টুডেন্টসদের সবার কাজে লাগবে। তো অনেক অনেক ধন্যবাদ স্যার আপনার ব্যস্ততার অংশের মধ্যে আমাদেরকে সময় দেওয়ার জন্য।
থ্যাংক ইউ শারমিন। আর আমি এই প্রেজেন্টেশনের পিডিএফ কপি তোমাকে আমি পাঠিয়ে দেব। ইউ প্লিজ শেয়ার উইথ দেম।
জি রাবিবা, তোমাকেও ধন্যবাদ। আপনাদেরকেও ধন্যবাদ। আজকে তাহলে এখানে শেষ করছি।
আর তোমাদের সবাইকে ধন্যবাদ, বিশেষ করে রাবিয়া, শারমিন, তোমাদের অর্গানাইজ করার জন্য, আর অ্যাটেন্ডিং যারা আছে তারা শোনার জন্য অনেক 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 ধন্যবাদ। ভালো থাকো
থ্যাংক
সবাই।
ইউ স্যার। ওকে স্যার।
থ্যাংক ইউ।
স্যার মিটিংটা শেষ করে দিচ্ছি।
ওকে, থ্যাংক ইউ,
ওকে
থ্যাংকস।
ওকে আদাব স্যার।
বাই।